Hello everyone, today we're going to talk about push-dose norepinephrine and reflex bradycardia. We've pushed our entire vasopressor approach here at MCHD to norepinephrine being our vasopressor of choice in everyone except for anaphylaxis, severe asthma, and bradycardic patients. This has to do with the receptor effects. Norepinephrine has a balance that's more favorable between alpha and beta agonist effects. It squeezes the vasculature, pushes the heart a little bit, but not quite as much as epinephrine, leading to less arrhythmogenic events. We mix 4 milligrams of norepinephrine in 500 cc's of saline. This gives us a concentration of 8 micrograms per milliliter of norepinephrine. Our adult push dose is 2 milliliters or 16 micrograms of norepinephrine. Remember, we're patient in hypovolemia, fluids first, and we're very, very careful to utilize pressors in patients who have a GCS of 15 unless they're clearly unstable. So what have we seen since we rolled out push-dose norepinephrine? Why are we talking today? We've seen a small but real number of reflex bradycardia cases. So what is reflex bradycardia with push-dose norepinephrine? Why are we seeing it now? We're seeing it because of the alpha effects. Norepinephrine has more vascular effect than epinephrine, more alpha-1 agonist effect. So what we're seeing is push-dose norepinephrine, heart rate drop. Expect this. It's brief, it's self-limited, but you have to know to expect it. In OB, they use phenylephrine, which is an alpha agonist primarily, and reflex bradycardia in that world is very, very common, up to half of the cases. So we see it with norepinephrine, not quite as much as with phenylephrine in the hospital, but it's going to be real and you're going to see it happen. So what do? Number one, don't slam the medication. We only slam one med, that's adenosine, so push slowly. Number two, if you see bradycardia after push-dose norepi, monitor your patient closely. Look at their mental status, their respiratory rate, their blood pressure, recycle the pressure, and if all those things are stable, then watch the patient and allow it to self-resolve, because 99% of these plus will self-resolve. If you need to treat it, if it persists greater than 2 to 3 minutes, you would add push-dose epi to give some cardiac push. If you need to go past push-dose epi, I would go to atropine second, and very last on the list would be transcutaneous pacing, and that would be probably a rare, if ever, occurrence. So watch your push-dose patients, expect reflex bradycardia, don't freak out, observe your patients, and these will self-resolve.